also want to welcome everyone to today's webinar. I'm thrilled again that we have three really exciting speakers. We have maybe even a different format today, but as usual, the goal is, of course, to exchange on a global level and to learn from each other. Having said this, I think we just start. First speaker will be Kim van Oudenaarde from Luzern, Switzerland. Please, Kim.
Thank you, Bruno, for the introduction. So today I will talk about the new radiology guideline for the soft tissue tumor imaging. And to start off, I have some warm-up cases for you, and I would love to hear the opinion of the public. So the first case, woman 58 years old, felt a nodule in her left caul for about 1.5 years, which is only painful when pressure is applied. Subjectively, there was no growth in the last 1.5 years, and the MRI shows a lesion of 2 centimeters. So question for the audience, how do you want to proceed? Is this a nice case for a watch and wait procedure? Would you like to establish the diagnosis using a fine needle biopsy or a core needle biopsy? Is this a great case for an excisional biopsy, or do you need more imaging first? So you can fill in your answers now. So we see this high signal intensity in the T2 fat suppressed image, T1 iso intense after gadolinium solid enhancement of the lesion, and also internal vascularizations are seen in the Doppler and ultrasound. So let's see the answers, if that's possible. So indeed, most of you would perform a core needle biopsy here. Very good. We move on to the second case. Healthy women, 62 years old, right-sided knee pain since a knee trauma 3 months ago. There was progressive swelling on the lateral side since then, and the patient reports blocking phenomena when walking. So we started off with a standard MRI knee protocol with proton density, weighted acquisitions. Then the radiographer called and said he's seeing something inside of the joint. And we decided to perform additional sequences. So at first the T2 star sequence, and then we gave intravenous gadolinium, which shows the intense enhancement of the lesion. 3.5 centimeters it measured. So what is your first differential diagnosis here? Is this a chondroma in the context of synovial chondromatosis? Is this a fibroma of the patellar retinaculum? Is this a large gout tophus? Is this a tenosynovial giant cell tumor? Or do you say it's really an unspecific lesion? I need more details. I hope you can fill in your answers now. I don't see the box now.
We have started the form, but there is something lacking. One moment, please. I'll try again. Doesn't allow by now. I'm very sorry for that. That's a technical issue.
Okay. So I move on then. Just keep it in mind, what is your preferred diagnosis here? Also a third question, I don't think maybe this won't function as well, but let's try. So how do you want to proceed to confirm the diagnosis? Do you say, well, no biopsy is needed, this is a clear diagnosis on MRI? Do you want to have a fine needle biopsy, a core needle biopsy, excision right away, or do you need more additional, do you need more imaging? So this is not functioning as well, I think. Anyway, let's move on. Just keep it in mind what you would have done here. So thank you for the first answer. And at the end of the talk, I will tell you what we did. So with these two teaser cases, I would like to introduce to you the new imaging guidelines from the European Society of Musculoskeletal Radiology. It is published end of 23, and it's a guideline written almost exclusively by radiologists, all specialized in sarcoma imaging. So among some of the last authors is a pathologist and two orthopedic surgeons from the Vienna University Hospital, where also the first author is based, Iris Neubauer. So indeed, this is part one about the initial workup of the primary tumor itself and about the role of tumor centers. Two more publications will follow in which staging in sarcomas will be addressed and imaging in neoadjuvant therapy and follow-up imaging will be discussed. So the guideline starts with a minimum required information we should have before performing sarcoma imaging. So this information enables us to come to a correct differential diagnosis. Quite honestly, I would like to have this information for all the scans I report, but good. So we would like to hear about the history of the lesion. When did the patient first notice the lesion? Was there any change in size? Was there a trauma, oncological history, surgery being performed? And about the lesion itself, is it movable? Is it painful? Are there any skin alterations, one or multiple lesions? And of course, when available, please upload the imaging in the PEC system when there is prior imaging. So then the imaging itself, we start off with ultrasound if the lesion is accessible and smaller than 5 centimeters. So for instance, a retroperitoneal mass are not really suited for ultrasound. Lesions that can be diagnosed using ultrasound only include simple cyst, a bursa, ganglion cyst, the lipoma, a foreign body granuloma with a proper history, the superficial fibromatosis, a muscle hernia, and a mortal neuroma. And in unclear lesions smaller than 2 to 3 centimeters, an excisional biopsy should be considered. Next step would be MRI, and of course MRI always prior to the biopsy. So we use the MRI for characterization and local staging of the mass. For lesions with indeterminate ultrasound features and for larger tumors. But you can consider MRI right away with clinical suspicion of malignancy if the mass is deep, by rapid enlargement, and by osseous or joint involvement. Then there are multiple benign soft tissue lesions that can be diagnosed using MRI only. So here's a list for you. But I have to say, I rarely have these classic textbook cases of a neurogenic tumor with a typical target sign and the vesicular sign. Or for instance, the myositis ossificans looks pretty wild in MRI, and we definitely need a radiograph with calcifications to confirm the diagnosis. And it's still hard to 100% call these benign lesions as such. So and we all know in the diagnosis of soft tissue lesions, definitely for the malignant ones, we depend on the pathologist who often gives the right diagnosis. Our role is definitely bigger in the bone tumor imaging. So I've got some quick examples for you where no biopsy is needed, like anatomical variations, accessory soleus muscle, could feel like a tumor, Baker cyst. So the bursitis with rise bodies in the semimembranosus tendon surrounding the tendon, typical lipomas here of the thoracic wall, the giant cell tumor intraarticular in the knee joint, the plantar fibromatosis. These are all lesions where actually no biopsy is needed because it's pretty clear what it is from the imaging perspective. Other topics being addressed in the guideline are the MRI protocol. Well, these are all recommendations and no requirements. So at least T1 weighted image, T2 weighted image with fat set, gadolinium in certain cases. Then the MRI report, what can you expect from us? So we should at least report location, size in 3 dimensions, the morphology, the signal intensities, the relation to fascia and other surrounding structures, multiplicity, the lymph nodes. And then at the end of the guideline, the role of tumor centers is being discussed. So I think the public today is quite aware of the importance of a tumor center. So the guidelines stated that any patient with a soft tissue tumor larger than 5 centimeters or with a clinical or radiological suspicion of malignancy should be referred, and the referral should be before any biopsy. So there are a few other guidelines for soft tissue sarcomas. However, the diagnostic part in these guidelines is pretty constrained. So the ESMO guideline mentioned a few words in line with the ESSR guideline concerning the role for ultrasound and the option for an excisional biopsy. And the National Comprehensive Cancer Network guideline sees no role for ultrasound, and they only mention MRI or CT in initial workup, and they don't mention an excisional biopsy. So back to our cases. The first case with the 58-year-old woman with a nodule in her calf. The case was first presented in a non-sarcoma center who referred to us. We performed a core needle biopsy, and histology showed a vascular type of leiomyosarcoma, grade 2. Chest CT was being performed, no lung metastasis, and then it was followed by an R0 resection, no adjuvant therapy there. So core needle biopsy was also what most participants in this webinar would have done according to the answers provided. Second case, 62-year-old woman with a pain and swelling of the knee. So I didn't see your answers because you couldn't give an answer, but from an imaging perspective, this was pretty clear that it was a tenosynovial giant cell tumor. That was our MRI diagnosis. And for the next step, we performed the core needle biopsy, which confirmed the diagnosis. The therapy for this patient is a watch and wait procedure, follow up in probably 2 years, or when the patient feels an increase in size. And by increasing complacency, you can directly opt for arthroscopic resection. Then my questions to the panel. So for the first case, what do you think of an excisional biopsy in this case, which should be considered following this guideline? So maybe I would like to hear the opinion of a radiotherapist or an oncologist. Was there any role for neoadjuvant treatment here? Would patient miss out proper neoadjuvant treatment? Or for a surgeon, maybe, is there a risk for whoops resection in this case? Second case, what do you think of no biopsy in this case, of a clear radiological diagnosis like a giant cell tumor? So let's start off with the first case.
So I think these questions are right on target, right? So you brought up radiation maybe first. Maybe Gabriela and Tom, do you want to comment from your perspective?
From my perspective, I always like to know what I'm treating, and I think the wide excision for this is appropriate. But I think if you do an excisional biopsy, I always worry, particularly if this is at a non-sarcoma center, that they're going to get into the tumor, they're going to spill tumor. So I think planning to be able to plan a wide local excision initially, I think is very helpful. And in that case, I would have performed a core needle biopsy. It's very accessible. The diagnosis is almost certainly to be obtained after the core biopsy, and then you can plan appropriate surgery from the start. I think for a small superficial sarcoma like this, a wide local excision is appropriate, unless it turned out to be a particularly infiltrative histology like a mix of Farber sarcoma, in which case I would favor adjuvant radiation. I'd be interested in what Gabriela would offer as well in this case.
Many thanks. So I think nothing to add. That's my opinion, my fully agreement as well. We need to know what we treat, and yeah. And whenever possible, pre-operatively instead of post-operatively, but anyways, we need to know what we treat.
Michelle, do you hear us? You're in backstage. Are you already among us? So maybe she will join us later. No problem. Is there what's the approach from the pathology side?
Hi, can you hear me? I've been speaking.
Oh, Misha, great. Yes, sure.
Hi, I don't know what happened. I got kicked out for a second. Hi. Yeah, so for the first case, I missed the history. So how big was it? And was it fast growing?
2 centimeters, and it was stable subjectively in 1.5 years, but we're not sure if that's correct.
Yeah. Yeah. I mean, if you really have a 2 centimeter stable lesion, I think excisional biopsy is going to happen a lot.
Yeah.
If you have the retrospectoscope and say, actually, that was a sarcoma, then of course you're going to biopsy it, core needle. But a 2 centimeter lesion that's been there for a long time, at the same time, it doesn't hurt to get a core biopsy, it's safer, and you just do it. And then for sure.
Yeah.
And so, sometimes on physical exam, you can really tell, like if it's truly benign, it feels different than a sarcoma. So if you can palpate it, there's certain palpable difference that you can. So I don't think it's wrong to do a core needle. I think it's probably the safest route, but definitely excisional is going to happen in the community for sure.
Yeah.
Michelle, what is your approach for the second case with this TGCT in the knee?
Yeah,
Would
great
you do
question.
an excisional?
I would just excise it. Yeah, if it's symptomatic, I would just go and excise it. Yeah, it's easy. It's really it's a very quick procedure because it really is it's not subcutaneous because it's in the joint, but it's not far to get down there, and it's a straightforward procedure. And but that's if the patient's symptomatic. If they're not symptomatic,
And if not, then you will watch and wait, or
I will
do the
watch
biopsy.
it. If they're going to wait and not do anything, it might be safe just to biopsy, so we know that for sure that's what we're following. But even if I would also be fine with just following it clinically, it would be sort of discussion with the patient.
Tom mentioned I like to treat, to know what I treat.
Yeah.
What do you say? What does that mean in your practice? When do you define the
Definitely.
exceptions?
Yeah, sometimes I just end up going with the odds, like an intra-articular mass that definitely looks like TCGCT. And the odds of it being something else are so low. And if that is a sarcoma that's intra-articular, you're still going to need to do an extra-articular resection or some large morbid procedure.
Exactly.
So whether you resect it primarily or not, it's already in the joint. So it doesn't really change the fact that you would have to do a large procedure. But the odds, if it's radiographically consistent with TCGCT, and it's a truly intra-articular mass with no concerning clinical history of rapid growth, then if it's 1,000 to 1, I would probably go with those odds.
And Bruno, in these cases, when I follow without a biopsy, I usually just plan to repeat the imaging at a shorter interval, maybe 3 months. And if it's stable, then I think imaging hasn't changed, the patient hasn't developed new symptoms. I think everyone feels more comfortable.
Yeah, indeed.
Agreed.
Exactly.
Agreed. Yeah, I agree with that. Yeah.
I like to sleep at night. I don't like to worry.
Yeah.
That's a very good
I know.
point. No, I like this discussion because there's no black or white, right? I mean, most often, but there are exceptions.
Yeah.
Do you have further questions?
Bruno, or?
Go ahead.
Yeah. So thank you for this discussion. So indeed, there are no real right or wrongs here. I mean, all patients, all doctors are different. And yeah, I think a doctor must at least know the guideline. And fortunately, this guideline has got very few requirements and very many recommendations. So there's plenty of room for your own decision. So I hope I was able to teach you the basics of the new European radiology guideline. So start off with an ultrasound for smaller and superficial lesions. Consider an excisional biopsy for smaller lesions. Consider no biopsy in real specific diagnosis, because sometimes it leads to more confusing, like simple error or malignancy could not be ruled out. So thank you very much.
Thank you so much, Kim. There is one more question. Dr. Murguia, a pathologist from Mexico. He says, regarding case 1, the case of corneal biopsy, do you perform immunohistochemistry to confirm the diagnosis, although the morphology is conventional for a leiomyosarcoma? Do they add a note that histological type can vary by tumor size? Does anyone from the pathologist wants to answer?
I'm happy to comment.
Please.
So I think this is leiomyosarcoma is one example where with really conventional histology, immunohistochemistry is not mandatory. In many practices, immunohistochemistry is performed, but I do not personally. I think it has a lot to do with expertise. In some practices where leiomyosarcoma, although it is the most common sarcoma, is not encountered very often, pathologists feel more comfortable if they have some support by immunohistochemistry. So there is some variability in practice, but with classic histology, I do not perform immunohistochemistry.
So very good, Jason. I saw that you recently published a paper on, what can be, let's say, how can molecular tests be avoided through immunohistochemistry to be more cost efficient? I think that would be also a very great topic for the future, right?
Sure, yes.
Okay, any further questions? Then I think we move on. Let's go to your interdisciplinary case, Jason and Candace, please.
Wonderful. We're so excited to be here, especially with all these wonderful panelists. We're going to present a case on a patient with undifferentiated pleomorphic sarcoma of the extremity. And this is the type of case that had many twists and turns and decision points throughout the course. And I think if the patient sought a second, third, fourth, fifth opinion at another sarcoma specialty center, may have gotten 6 different opinions on how to proceed. So it's a very complex case, and I just wanted to welcome the panelists to join in the discussion. And I have studied the presentation with different questions to the panel as well to just see how we might approach this case differently. But I wanted to introduce my colleague as well, Dr. Jason Hornick from our sarcoma pathology department.
Yeah, it's a pleasure to be here. We're very excited to present this very interesting and challenging case that has implications for all the subspecialists in our multidisciplinary groups.
Yes. And to showcase that, at the bottom of the slide, you see all of our colleagues here at Dana-Farber and Brigham and Women's who participated in this patient's care, and I just wanted to acknowledge them as well. All right, so this is a healthy, lovely woman in her 70s with no relevant past medical history, as you can see, and she presented with a new left thigh mass. Her family history was unremarkable, no family history of sarcoma or other relevant malignancies, and she was very active at baseline, good performance status before her diagnosis and finding of this new mass. So she presented around December of 2022, and at that time she noticed that she was having increasing pain in her left anterior proximal thigh, and ultimately in December she started to feel a mass there, and that's when she presented. So an MRI of the femur was obtained, and as you can see, that shows a large anterior left thigh mass measuring 15.6 centimeters in its greatest dimension. The mass was extending along the anterior aspect of the femur, and there was no evidence of invasion. On imaging, you could see that there's mixed components. So there was a prominent cystic and also solid components within, with heterogeneous enhancement and fluid levels. And you can also see that the mass was displacing the neurovascular bundle medially. At the time, the patient had staging with a CT chest, and there were no metastases noted at that time. And she then proceeded to a core needle biopsy, and I'll turn it over to Dr. Hornick to discuss those findings.
So this is the scanning. Could you go back one? This is the scanning image of the core needle biopsy. You can see we have multiple cores. Some of the areas in the core are quite cellular and purple. That's going to be the tumor. Other areas are predominantly blood and necrosis. As you saw from the imaging, there were large areas of fluid density with hemorrhage and necrosis. Next slide, please. So I'll show you a few different areas. These are the cellular areas of tumor. And the first thing you notice is this is a really highly pleomorphic neoplasm. The nuclei have widely varied size and shape. There's mitotic activity. There's no architecture. There's just sheet-like growth of these cells. Next slide, please. And in other areas, there are very prominent osteoclasts, or as we call them outside the bone, osteoclast-like giant cells. These are the multinucleated cells that have purple cytoplasm. They are non-neoplastic, so they're a reaction, as it were, to the tumor. And again, in these images, intermediate and high power, you can see the very large, bizarre nuclei with coarse chromatin and mitotic activity. Next slide. So I'm just going to spend a few minutes before we move on from the case to talk about what we do as pathologists when we approach pleomorphic sarcomas. And understanding epidemiology is so helpful, really, for all of surgical pathology, but it applies, I think, almost more than anything for bone and soft tissue tumor pathology. We have to understand relative incidence of various pleomorphic sarcomas based on anatomic site. As we will discuss in a moment, on a resection specimen, sometimes sampling is required to identify focal areas that allow us to make a specific diagnosis. And then, as I always like to say, apply immunohistochemistry judiciously. Next slide, please. So let's think about the two major compartments where we consider pleomorphic sarcomas. When we start off thinking about the extremities and trunk wall, we have a few that we encounter very often in our sarcoma practices. Those are myxofibrous sarcoma, which is the most common sarcoma of the elderly, undifferentiated pleomorphic sarcoma, and leiomyosarcoma, overall the most common sarcoma. Leiomyosarcomas most often are spindle cell neoplasms, but some examples have quite striking pleomorphic morphology. Other sarcomas in this histologic bin are very rare. We certainly see them when we work in sarcoma multidisciplinary practices, but they're very uncommon. Next slide. In the retroperitoneum, it's very different. In this setting, almost all of the sarcomas with pleomorphism are going to be dedifferentiated liposarcoma or leiomyosarcoma. And that's all I'm going to say for this moment in terms of that. Next slide. So in terms of histology, pleomorphic sarcoma is one of the categories where purely old-fashioned microscopic examination leads us to the final diagnosis in many cases, in at least half the cases. There are some features we look for to help us come to a diagnosis. I've listed three of them here: myxoid stroma, the glycosaminoglycan-rich extracellular matrix material, lipoblasts, and bone matrix production. And I've highlighted in red the classic tumors that we would consider when we find this. Myxofibrous sarcoma, we have to find the stroma. Lipoblasts in a pleomorphic sarcoma defines pleomorphic liposarcoma. And finally, in a sarcoma of soft tissue with no other distinguishing features other than bone matrix production, that's an extraskeletal osteosarcoma. Unfortunately, as you see from these tables, there are other tumors that can confuse us, but I've just mentioned the main examples. Next slide. So let's just very briefly take a tour of these tumors. This is a myxofibrous sarcoma. The scanning image on the left shows this classic lobulated architecture, big expansile lobules. But when we look at a high-grade example, as we see on the right, much of the tumor is composed of very cellular sheets of very pleomorphic atypical cells. We look for myxoid matrix and those slender, curvilinear blood vessels. Next slide. In contrast, pleomorphic liposarcoma, we're looking for the lipoblasts, these hyperchromatic nuclei that are indented or scalloped by the vacuoles of lipid, as you see on both the images on the right. Most examples of pleomorphic liposarcoma are dominated by morphology indistinguishable from undifferentiated pleomorphic sarcoma, as you see there on the left. Next slide. And here's bone matrix being laid down by these malignant cells in an osteosarcoma. You can see the eosinophilic matrix material that's beginning to calcify, that purple area on the upper part of the panel. Next slide. So then the question becomes, when do you need to do immunohistochemistry? And there's already been a question about the radiology presentation along those lines. We do have some very helpful lineage markers that can lead us toward a specific diagnosis. I've listed some of them here. Don't forget, as pathologists, exclude metastatic sarcomatoid carcinoma and exclude melanoma. You really can be caught out if you don't think about the possibility you may be dealing with a much more common tumor type that is not a sarcoma, that is mimicking a sarcoma. We do have some nice markers of dedifferentiated liposarcoma as well. Next slide. This is a leiomyosarcoma. In addition to the spindle cells with pink cytoplasm, we have bizarre pleomorphic cells. And in this setting, immunohistochemistry is very helpful to distinguish this tumor from an undifferentiated pleomorphic sarcoma. Smooth muscle actin and desmin are positive to help us. Next slide. Pleomorphic rhabdomyosarcoma is the brightest, pinkest tumor in the group because the tumor cells are filled with the desmin intermediate filament, as you see on the top. In contrast, the skeletal muscle transcription factors such as myogenin are very limited in extent in this aggressive variant of rhabdomyosarcoma of adults. Next slide. And finally, dedifferentiated liposarcoma. This is a classic case with an en bloc resection, including the kidney. The fleshy solid area of the tumor is the non-lipogenic pleomorphic component. The fatty area is the well-differentiated liposarcoma, where we have a marked variation in size of the fat cells, occasional very dark tumor cells, and the fibrous stromal component. Next slide. And MDM2 immunohistochemistry can be very helpful to support the diagnosis in the right context. Next slide. But in many practices, fluorescence in situ hybridization for MDM2 will be performed to make the diagnosis. You see the huge numbers of copies of the MDM2 gene in the two neoplastic cells on the left. Next slide. And my final point, coming back to our case, think about malignant neoplasms that have reactive osteoclast-like giant cells. There really aren't very many. Undifferentiated carcinoma, especially from the pancreas, those tumors can have lots of osteoclasts. Whenever we see osteoclasts, you should think of osteosarcoma. And the last two are leiomyosarcoma and undifferentiated pleomorphic sarcoma. Next slide. So this is an extraskeletal osteosarcoma that does have some osteoclasts, those purple cells on the left. Next slide. So now back to our case. So we're looking again at the same images we saw. Next slide. Immunohistochemistry was performed and nothing was positive. All of the markers we would imagine to help us diagnose carcinoma, melanoma, leiomyosarcoma were negative. Next slide. So this is an undifferentiated pleomorphic sarcoma with prominent osteoclast-like giant cells. Next. So finally, when should we diagnose what we now call UPS? This is a diagnosis of exclusion. We have to sample, make sure we're not missing lipoblast, bone matrix, myxoid stroma, perform a directed panel of immunohistochemistry. If we exclude the other possibilities, we're left with this diagnosis. Next slide. And this is another example, bizarre, huge pleomorphic cells that are multinucleated and a very high mitotic rate. Next. And back to you, Candace.
So this patient, after a diagnosis was rendered, she came and saw us at Dana-Farber for a multidisciplinary evaluation with medical oncology, radiation oncology, and surgery. And at the time that we met her, she was having intense pain required a wheelchair for mobilization. She was recently hospitalized for pain control. She was losing weight due to poor oral intake from the pain. So really clinically declining, but through her local evaluation before she came to us, she was set up to begin radiation the following week. So here's my first question to the panel. For this patient who has a new diagnosis of a large, very symptomatic UPS of the extremity, with radiation set up to begin in 1 week, what would you do? Would you initiate radiation as planned, then proceed with surgery, or the opposite, perform surgery first and then go for radiation? Would you consider chemotherapy and radiation concurrently and then proceed to surgery, or any other thoughts?
Candace,
maybe
my
we started.
first thought.
Please go ahead, Tom.
In December of 22, she would have been eligible for SARC 0032, which is a study of neoadjuvant pembrolizumab with radiation versus radiation alone. Her performance status, however, may not have allowed her to be included, in which case, at least our society recommendations are for large primary thigh sarcomas to proceed with preoperative radiation.
I'm glad that you brought that up, Dr. Delaney, and we did consider SARC 32, but you're absolutely right. Her performance status would have excluded her. So ultimately, we did not put her on that study, but we did think about it.
Hi. I would go ahead with resection and just let her know that it's not what we would normally do, that would end up requiring her likely to have a higher dose of radiotherapy. But just to let her know that you're going off what would be the standard of practice, and it would be meant for palliation. It sounds like she's not doing well. She's only going to get worse, and her performance status can actually deteriorate even more. She may not even make it to surgery. So sarcomas generally don't hurt, but sometimes they do, and they can cause perineoplastic syndromes that cause you to be weak, etc. I've seen anemic patients. So if the sarcoma is making her sick, I would go ahead and resect it. That's just I'm just as a surgeon, that would be my first inclination.
So we would clearly go for fast ultra-hyperfractionated radiation first.
Good thought.
And then just go for surgery 1-2 days afterwards. So
yeah, that would be good too. I mean, of course, I'm thinking in the age where you do 5 weeks
right.
and you wait another 5.
But,
yeah, that makes perfect sense. Yes,
I would agree. Do not lose 2 months for any, yeah.
Tom, what do you think about ultra-hyperfractionated radiotherapy in this situation?
I think that's an excellent thought from Gabriella, particularly for a patient who's symptomatic. I think that really combines the best of both worlds. Neoadjuvant radiation can be given and surgery can be done with a relatively short delay. It's a very good thought.
Candace, what is the thing in your group regarding, you are proceeding now, but just regarding ultra-hyperfractionation or hypofractionation, normal fractionation, what is discussed in your MDT?
We have not implemented this yet, and I think at the time that we saw the patient, the data may not have been out yet.
Yes.
But we're not adopting it as standard of care yet. We still do offer the 5 weeks. But in this situation, it is very attractive to do that path. Agree.
Javier, you are also among us. What is the approach in Spain?
Yeah, I think our approach is similar to Italy and other neighbors countries. We are facing a high-risk localized leiomyosarcoma, a high-risk localized soft tissue sarcoma, and applying both criteria, clinical pathological criteria, which is the 3 ingredients in the same patient: larger than 5 centimeters, deep tumor, and grade 3, or applying the nomogram, the circulator in this case, for which the 5-year overall survival in this specific case would be 32%. So in both, applying both criteria, the high risk, according to our 2 decades of experience, these kind of patients benefit from chemotherapy. It's true that this should be full dose chemotherapy, and the issue is the age. 70 usually is the border, but today we are focusing on the biological, no chronological age, and sometimes 70 years old is adequate for chemotherapy administration. Actually, we have prescribed up to 75 without any substantial toxicity. It's true that myelotoxicity is an issue, and we should be appointed with in the nadir time, but usually it's manageable. So if we want to get a 65% of overall survival in this specific subset of high-risk localized disease, then chemotherapy should be into the equation. And I was reading the last presentation of pembrolizumab and radiation therapy. Is a good and positive study, but both Kaplan-Meier curves for relapse-free survival were circulating lower than desirable for the intermediate, let's say, and high-risk population. So I think in our country and other countries, after more than 1,000 patients treated in randomized trials, we are very persuaded that chemotherapy is adding value in survival. So this is our discussion with the patient.
Great. Yes, that was definitely a consideration as well. I think her declining performance status was very worrisome. She looked very ill when she came and met us, so I don't think that she would have been a good candidate for multi-agent chemotherapy, but certainly in the right patient would have considered that as well. So this was our list of pros and cons for each point. It was brought up to initiate radiation and then proceed with surgery, and this was our usual approach as well. But we were worried that she would not get through the radiation course. Of course, with a hypofractionated scheme, maybe she would have done a bit better. For point 2, going to surgery first, this was something that I was actually advocating for because I was really worried about her ability to get through radiation. But in a multidisciplinary discussion with colleagues, it was brought up that there would be a higher dose, particularly to the femur, and that would put her at very high risk of fracture. So this was not favored either. And then we just discussed about her performance status and being concerned that she would tolerate chemotherapy. Ultimately, she was able to have good supportive care, get through radiation, although it was a rocky course, and complete radiation in April. Pre-op MRI unfortunately showed further enlargement of the mass, now measuring up to 26 centimeters. It was encasing the femur nearly 270 degrees around. It was now encasing the femoral artery as well, medially, as you can see in the image, and there was edema throughout the leg. And her performance status kind of matched this picture as well. She was barely hanging on, I would say, and there were concerns about going to surgery. And then in addition, we found that she developed a lung metastasis in the right upper lobe seen here. Ultimately, when she, sorry, was there a comment? No. Ultimately, she did go to surgery and could not spare the limb, and she ended up having a left hip disarticulation. And on pathology, a 22 centimeter UPS was diagnosed. There was, in fact, extensive treatment effect with over 95% necrosis, and the margins were negative, although the closest was 0.6 centimeters. Her post-op course was pretty complicated, actually. She had aspiration pneumonia. She was in the hospital for 3 weeks and was on oxygen towards the end of that stay. And as part of the workup for the hypoxemia, a repeat CT chest was obtained, and that showed an enlarging nodule, the one that I pointed out earlier. as well as multiple new nodules and a 4 centimeter mass that you can see there in the pelvis already, just in an interval of 3 weeks. All of this arose, and she was clinically very deconditioned. So now I ask the panel again, what would you do in this situation? Give more recovery time, start systemic therapy, and if so, what would you begin, or pursue local therapy for these different sites of disease, or recommend something like hospice or best supportive care?
Javier, maybe again,
Yeah.
your input.
Yeah, I think it depends on the general status, as Candace said. If the general status is enough, ECOG 1, sometimes ECOG 2, chemotherapy should be the first option. It's true that the combination of anthracyclines plus ifosfamide we are offering to UPS in general, but it's true that this should be individualized according to the general status. If the patient is symptomatic or surgical rescue is in the horizon, maybe we prefer the combination, but depends on obviously on the ECOG. So we have a very good experience with chemoimmunotherapy in Immunosarc trial with a combination of epirubicin ifosfamide plus nivolumab, and the percentage of overall response rate is huge, is around 70%. And obviously, this within a clinical trial is not standard care, but this is a new concept. Maybe in the future will be important in our patients, exploiting the concept of immunogenic cell death. But as a standard approach, chemotherapy could be well taken. Depends on the general status, obviously.
Considered the same thing as well. She had a very fresh surgical wound, still ongoing pain and poor recovery. So I also thought about immunotherapy in her case. And the patient strongly desired to continue to pursue treatments and was not ready yet to have best supportive care as her path. So we considered immunotherapy. And this group is well aware SARC-28 was the first to look at pembrolizumab monotherapy in soft tissue sarcomas. This enrolled 4 histologies: leiomyosarcoma, liposarcomas, UPS, and synovial sarcoma. And in the initial data, it was clear that UPS was special. There were 4 responses, some, as you can see, very durable, and really nice tumor response, which led to expansion cohorts and included UPS and dedifferentiated liposarcoma. And those data are shown here. Overall, the objective response rate for pembrolizumab monotherapy was 23% in UPS. But how do we predict responders? Obviously, that's key, because 4 out of 10 isn't 10 out of 10. So how can we do better to select patients? So these are data from the correlative analyses from SARC-28, and this group used TCGA RNA bulk-seq data to cluster sarcomas based on their RNA expression. And you can see that identified 5 different sarcoma immune classes that are shown here. And each one of those classes really did include a lot of different histologies within them. But you can see the one far on the right, which is immune class E, was something special. That had the highest lymphocytic infiltration, had the highest expression of CXCL13, which is associated with TLS, or tertiary lymphoid structures, and then also had the highest immune checkpoint expression. So how does this correlate both with histology and also with responses? So when applying this sarcoma immune classification to the cases in SARC-28, you can see that immune class E was the red bars, which you can see scattered throughout this waterfall plot. Some of the best responders did have sarcoma immune class E. Excuse me. And looking histologically, tertiary lymphoid structures were identified in the sarcoma immune class E cases. And as you see, these are CD20 lymphocytes, CD20 positive lymphocytes with PD-1 expressing lymphocytes and T cells surrounding. So is this a biomarker for immune checkpoint inhibitors? Well, that was investigated in the Pembro-Sarc trial, which was looking at a low-dose cyclophosphamide, which was thought to deplete the regulatory T cells and then introduce pembrolizumab. And the study incorporated TLS as a biomarker later on. They screened 240 patients for TLS and 48 had positive or were positive for tertiary lymphoid structures, and 35 of those were included in the study, and that included the histologies shown here. And overall, the TLS biomarker was enriched in the responders, as you can see, but I also point out that there are cases that had TLS yet did not respond to the therapy and had progressive disease. So this is not a perfect biomarker, but it is intriguing, and you can see a nice spider plot here showing that a lot of the cases that did have TLS had nice durable control and several achieved responses. So for our patient, did we look for TLS? Unfortunately, we could not. It is not standard. Also, we had very limited sampling of the primary tumor, as you saw from Dr. Hornick, where we showed the overall of the core needle biopsies that were obtained from the primary, and then post-radiation, the mass was highly necrotic. So it was not, we could not evaluate for this, and nor is it standard to do so. PD-L1 immunohistochemistry is also not done routinely, although can be obtained on certain commercial platforms that incorporate next-generation sequencing. We did perform our own in-house targeted exome sequencing called OncoPanel, and that showed a TMB of 0.76. And as usual for UPS, chromosomal instability, frequent copy number alterations, and a TP53 mutation. Ultimately, I did start pembrolizumab because I felt that it was the best choice for this patient, and luckily it really did turn the patient around. So you can see here, this is from what I showed in May after 6 cycles of Pembro, and really nice response in that lesion. And overall, her pelvic mass was initially controlled, but in September, it did start to grow again. So this Pembro at least allowed her clinically to recover. So she now has a better performance status. Her pain is under much better control, and she's in good shape, tolerating Pembro well otherwise. So what would you do in this situation where you have good control in the lungs, but one side of disease in the pelvis that's no longer controlled on immunotherapy? Would you change systemic therapies or offer surgery to this site of oligoprogression, or continue Pembro and offer radiation therapy?
This was the
Any
pelvic
comment?
mass, the only location for progression, or
Correct.
there were more lesions?
Nope, that's the solitary progressing lesion.
Okay. So radiation therapy plus pembrolizumab could be appealing because other locations were under control with anti-PD-1 agent. So maybe taking the opportunity of potential abscopal effect or something else could be appealing to test.
Yeah, I would support this approach. Thank you. And probably we would try to put some lattice vertices inside the lesion. Maybe. It's always a question of the neighborhood, you know.
Gabi, maybe explain a little bit lattice.
Spatially fractionated radiation therapy in terms of 3D technique. So you can put some hotspot vertices inside a moderate homogeneous dose on the tumor. And that shows, according to literature, some amazing results in some patients. So we would try that probably.
I think that's a very good thought, particularly with the periphery of the tumor is a budding bowel. So I think the lattice has a lot of appeal.
Where there's a lot of bowel in the proximity and also bone as well.
Yeah, but there's still quite a lump of tumor. So as long as you are inside the tumor, for sure, with your hotspot balls, you're fine. So it's a question of where do you put the hotspots. And sometimes it's just one or two. When you have a bigger mass, you can put as many as you like. And we all still do not know which is the best number of vertices and so far, you know. It's still a kind of open field.
That's a great suggestion.
Yeah.
I think that we didn't do anything that technical, at least not to my knowledge, and we
Okay.
the patient.
It's quite simple for institutions performing stereotactic radiation. It's kind of simple.
Great. So the patient got through radiation that did offer good control to that left pelvic mass, and she continued on pembrolizumab. Completed 9 cycles as of December, but unfortunately had a spike in liver enzymes with elevated AST, ALT, and ALK phos as high as 1400. So in this situation, we diagnosed her with an immune-related hepatitis from the pembrolizumab, and she was started on 1 mg per kg of prednisone while the pembrolizumab was held briefly. She did make a quick recovery, and there was no liver dysfunction identified. So bilirubin remained normal. Her synthetic function with albumin and INRs were all completely intact. So then the next question was whether or not to re-challenge with the pembro or move on to something else. Again, at this point, all of her disease is still well controlled. So you do hate to move on from a therapy that's helping. But I wonder if others have experience in this situation and what you would do.
I have a comment, not to answer your question right away, but I think that response is phenomenal, and it's very encouraging to see that in some cases immunotherapy will be effective, at least for a period of time. But we've seen responses like that with cytotoxic chemotherapy. So I think it's another arrow in our quiver, another option. I'm not sure it would be better. Like, do we know that pembro is better than cytotoxic, or is it just a better side effect profile?
I think it's just a different side effect profile, frankly. I think that in this patient, the advantages were that she, I think, would have had a really hard time getting through a really heavy chemotherapy course. And luckily, up until this point, she tolerated pembro perfectly, like had 0 side effects until we started to see these changes in her labs. So it was a nice option for her.
This meeting is being recorded.
Right. So then at this point, you know, she's got controlled disease. You might as well wait and see how things go, and then switch if she progresses. Switch back. Yeah. That's my thoughts.
Javi, what are your thoughts?
Yeah, in my experience, re-challenge with anti-PD-1 or anti-PD-L1 compounds after grade 3, grade 4 toxicity, immune-mediated toxicity, is tough. It's hard to do, because usually reappear the problem, and if you need high dose of corticosteroids to control this kind of immune-mediated side effect, then maybe it's not very useful the treatment. This is my experience, both with liver toxicity and also with neurological toxicity, but sometimes maybe can be solved. I haven't this experience, and then re-challenge could be done, but again, this is not my experience. So I will change towards maybe, if you know, wood problems with anti-angiogenic as pathopanib, and that could also potentiate the immuno effect of pembro, maybe can enlarge this effect. I don't know, but I would be afraid to make re-challenge in this context.
Yes, I had the same concerns as well. The patient was really hoping to stay on immunotherapy. And I just looked into the data. I hadn't as much experience with restarting after grade 3 liver toxicity. So what I found was that this is frequently encountered. Up to 7% will have elevations in liver enzymes, but only 1% are grade 3 or higher. Obviously, that's with monotherapy, and it's even higher with CTLA4 PD-1 inhibitor combinations. It is typically asymptomatic, and liver synthetic function is typically intact. So one may consider a rechallenge, and here are the numbers for what to expect. Only 20% have, this is in melanoma patients, by the way, but only 20% have recurrence of immune-related hepatitis on rechallenge for all cases, but for the grade 3 or higher, it's up to 40%. And interestingly, the severity of the initial hepatitis does not predict the severity of the recurrent hepatitis. In other words, if a patient had grade 4 hepatitis and unfortunately had recurrence of it after rechallenge with Pembro, for example, it would not mean that they had grade 4 hepatitis again. They may have a lesser grade. So, and then also there are data showing that patients that have pre-existing steroid at the time that immunotherapy is started, those patients tend to have worse outcomes with immunotherapy, but ones that require prednisone or steroid for an immune-related adverse event, that those patients do not have worse outcomes. So all considered, and especially considering the patient's preferences as well, I felt it was worth a try to re-challenge with Pembro, and we did, and the same thing happened. So luckily it was also resolved quickly. There was no liver synthetic dysfunction, but we did feel at that point that it was the right decision then to move on from pembrolizumab. So at this time, with the hepatitis, she also had disease progression. This nodule from the start still remained stable, but this one was new. And then this pelvic tumor, which was previously nicely controlled, was starting to grow. So in light of all of this, it was absolutely time to change therapies. And I think I have another prompt about how you would proceed. But I'll just give our opinions in the interest of time, what we had discussed. First, we thought about considering a multimodality approach with radiation to select nodules and maybe surgery to the primary pelvic tumor, and perhaps after that, starting on a different systemic therapy. But now that we were still concerned about surgery to that pelvic mass and the feasibility of that and the patient's ability to tolerate surgery. Now we're also dealing with an irradiated field. So that was felt to not be the best option. And also with the lung progression, we were worried that this will forecast future distant relapse. So we just felt that changing systemic therapies made the most sense. And at this point, I considered anthracycline and gemcitabine as options, and also pazopanib as well, for the reasons that Javier mentioned. But I ended up starting gemcitabine 1,000 milligrams per meter squared on days 1 and 8 of 21-day cycles. The patient also was had some travel plans coming up, and maintaining a good quality of life was really important to her. So although I considered a doublet with docetaxel, for example, this was better aligned with her wishes in terms of how she wanted to feel on treatment. And we talked about we would start, and if we needed to add a doublet, we could consider that in the future. But luckily, she's had a nice response to the gemcitabine monotherapy, and this nodule is stable. This mass has also reduced in size, and she continues to have stable disease and feels very well and tolerates gemcitabine monotherapy perfectly. So with that, I will summarize our case. As this group knows, soft tissue sarcoma management is complex and is highly individualized. As much as we can write guidelines, it ends up being a decision for each individual patient, depending on exactly what's going on and what their preferences are, what their performance status is, what their support systems look like, and all of these factors get incorporated, which makes for a highly individualized management plan. And this case, I think, especially shows the value of multidisciplinary care and discussions at each inflection point. And it's so nice to work with colleagues that can share in these decisions and really develop the best plan for the patient. And I think all the panelists that chimed in today, which shows some of the, I think, discussions that we had behind the scenes as well. In this case, I think one takeaway is that PD-1 inhibitor really provided significant benefit for the patient. It stabilized her rapidly progressing disease. It was a critical bridge to standard chemo, which I'm not sure that she would have tolerated at the time that we initially started the immune therapy. So I was really grateful that she had such a nice response and great quality of life while she was on the PD-1 inhibitor. I think IO incorporation to usual practice is imminent. And I think what we really need to really push this along and incorporate it into our practices is reliable biomarkers and also mature data from the completed and ongoing studies. SARC-32 was brought up. Other combination trials are ongoing in combination with chemotherapies and other agents. So these will all be important for us to look out for as the field evolves and as we continue to treat patients. So with that, I will thank everyone for your attention and for the panelists for participating. And if there are any final questions, we can address those now.
Any final word on, let's say, this so far great outcome? Really, congratulations. That's awesome. Maybe just because also Jason made a very nice overview, I would like to ask the pathologist in the panel to comment. Are there any questions specifically to Jason?
Jason, that was a really great case. I have to say, for myself, I just ignore the lymphoid aggregates when I look at slides. Like now, do you start paying attention to like the TLS, in your sarcoma cases?
I think about it a lot. To be honest, I rarely see them, despite these papers that look like, wow, 20% have TLS. I don't believe it. Like, I don't understand where they're coming from, because seeing well-defined lymphoid follicles, almost never. Like, I'm sure that Thomas, you're nodding your head. So
I think
really,
the same.
I don't know where they are.
Yeah. Yeah, that's a problem, and it's also the problem of the sampling. We have a tumor which is 20 centimeters large, and we all know, heterogeneity is the first word you take in the mouth when you discuss the histology of the sarcomas. And then you have, those core biopsies, which is less than 0.5% of the tumor volume, and you should kind of, explain. And also, you just kind of, lymph node lymphocytes in this respect are not really. Then you have some necrotic tissues, and you have a specific reaction, and so on and so on.
Yeah, thank you, Beata. I really think that it's multiple problems all coming together, because so many patients are diagnosed on a core needle biopsy, and patients with aggressive disease or very large tumors, radiation and sometimes chemotherapy are performed in the neoadjuvant setting, and then you can't assess for a tertiary lymphoid structure at that point. So unfortunately, I don't think that's the biomarker we're going to be looking for. I think we need something else that is still to be discovered.
I mean, our oncologist, sorry.
No, you first.
Our oncologists, they start asking for PD-L1 IHC on a lot of our sarcoma cases, and we do it, but I have trouble because there's no criteria, right, in sarcomas regarding like the CPS and TPS score. So I actually just end up showing my thoracic pathologist colleagues, can you help me interpret the CPS score? And it's very rare for us to have high PD-L1 expression. So I'm not sure that's like a good biomarker either for sarcoma. And as we know, they often have low TMB as well.
Yeah, Josephine, I totally agree. I think it's entirely irrelevant, and I've never run it, and I never would. And luckily, my oncology colleagues know better than to ask me for a PD-L1 immunohistochemistry. I also do a very high volume of gastrointestinal cancer cases. That's my other area. So we do it all the time on upper GI, and then we pretend that we have a number that we throw out to put on the report that is hand waving and, in my opinion, also fairly meaningless. So I'm very unexcited, to put it mildly, on PD-L1 immunohistochemistry as a biomarker. We know the therapies are wonderful, but PD-L1 immunohistochemistry is a very poor biomarker. And for
Absolutely
sarcoma,
agree.
for sarcoma, there's no way it would be of use. I would never believe it. We need some other biomarker that's going to be genetic or multiplex. I don't know what that is.
Well, it's probably try and see it because at the moment we really don't have anything. So PD-L1, okay, we do it and it's positive, it's negative, but the clinicians do whatever they want. So if they have this option, they will go for it anyhow. So it just kind of alibi kind of alibi to have it a go. But yeah.
Thomas, please.
Do you use sometimes NGS in younger patients for a screening method for molecular targets, or is it so expensive, or is it worthwhile? I don't know.
Yeah, I mean, I think that it's a tough question to answer, because the question really is, what is the goal? I think in sarcoma as a whole, NGS has so much value as diagnostic testing, as you all know, and as Josephine does as well. And Beata, I really think that identifying targets is sadly not so great. I mean, certainly we have kinase fusions that we occasionally find in young patients, but in the aggressive sarcomas, I think that's very uncommon. So I don't have a great answer. I'd be interested in others' comments as well.
I think from a treatment perspective, it is rare. I agree that we find something actionable. However, the way that phase 1 is going, so my other hat is I'm a phase 1 liaison for our sarcoma group to our phase 1 department. We, I would say 90% of our trials are molecularly selected. So unless you have the NGS, you don't know how to plug the patient into a trial, unfortunately. There are very few all-comer studies that will allow a patient with sarcoma to enroll. So the NGS is highly valuable to find those potentially actionable regimens that could be gotten from a clinical trial.
Thanks.
So my thing is, sometimes if you do it on UPS and you find some, some random translocation, even involving one of those hot targets, does it have a clinical meaning? So that's another, because those tumors are so complex, and the genetic level that sometimes can be just a bystander, or it's not a driving power of this tumor. So I'm quite skeptical. From time to time, we have this, a request for complicated and tragic tumors or complicated histories. We do it, but usually nothing comes out. Especially for pleomorphic sarcomas.
Yeah,
they're too complex and probably have multiple drivers. So does targeting one driver really impact the tumor? Yeah.
Josephine, you have a comment?
Yeah, we also get that request a lot, and then we set it out, and sometimes they will be like, oh, let's look for TMB to see if the sarcoma is like a immune checkpoint inhibitor target. But then as we all know, it's very rare for sarcomas to have like a TMB greater than 10, and so that's like super low yield, but then we still do it anyways. But yeah, I agree with everyone. I have yet to see like a pleomorphic sarcoma that have so-called like broad NGS testing done with DNA variants, and they found anything that is actionable.
Right. I mean, I think at least we have the marker of UPS, as you showed nicely, Candace, from the studies and from this extraordinary case. UPS is a very good type of cancer to treat in this fashion. And even if the response rate is not perfect, it's actually surprisingly high. So I think that's very helpful.
And
sorry.
Sorry, yeah.
Yeah, that remind me, we had a case where we signed out as high-grade pleomorphic something sarcoma, and then the oncologist specifically request us to add an addendum to say UPS, we favor UPS or something like that, so that they actually have an indication to treat with immunotherapy. So that really impressed me. And so it seems like we have some kind of biomarker hidden concerning UPS that we just don't know that could predict response. We just don't know what that is.
Okay, I guess this was the final word. We have still lots of things to be done, to learn. I think we only have to thank first all the three speakers. You enriched our day, our knowledge, also discussion that you stirred. It's just, again, fascinating. I really thank you so much, but also the panel. First, to take your time to participate, and then to contribute your thoughts and to exchange. I think this is the way to go also for the future. And I'm very happy that so many shared the time with us in the audience. I know that many were not able to participate, but who are eager to see the video on YouTube then. So if there are any questions, any thoughts, any comments, please do not hesitate to let us know. We want to improve. If you want to present or a case in the future or a topic in the future, please contact us. I mean, we have room for the future and lots to learn. Thank you so much. Wish you all a good rest of the day. And I give back to Eugen and his team, who did again a wonderful job. Thanks so much.